So is progressive or heart failure, especially with reduced ejection fraction, different in Indian patients? So heart failure, bigger challenge, not only globally, but India, where with mean patients 53 years in hospital mortality is 38%. That means one of the third patients, they can die during the hospital stay. And post-discharge mortality in within 6 months is 26%, which is highest if we compare globally. Post-discharge mortality globally is just 8.6% in 6 months. So there are different reasons in India because it affects early. If we compare it globally, 73 years versus 53 years, high mortality, high morbidity, hospitalization, in hospital death, all things are very worse in comparison to the globally. 23 Indian patients with heart failure die within 1 year of diagnosis. So that means 1/4 of the patients they die within 1 year. The survival rate of heart failure are worse than the most cancers, bowel, bladder, or breast cancers. So prevalence of heart failure in India, the truth is it is a very menace, big menace, 8 to 10 million patients with 1% adult population. Mortality is high at the tune of 20 to 30%. Medical adherence, it ranges from 25 to 50%, which is a major concern because if somebody has a proper medication, we are able to reduce the morbidity, mortality, and worsening of the heart failure. Moreover, Indian patients are young, and the incidence of hypertension in heart failure is approximately 42%. 5-year mortality, if key points, we see that 3 out of 5 patients they die during the 5 years, and mean survival is approximately 3 years in young cohort. Lack of guidelines directed medical therapy, especially in patients those who are reduced ejection fraction, and only 25% of the patients they were discharged from the index hospitalization are on guideline directed medical therapy. That means we are not giving proper medications to 3/4 of our patients, maybe because of lack of knowledge at the level of physicians, lack of compliance, or there could be multiple reasons. Maybe sometimes financial matters also. So interventions aims at increasing the guidelines directed method to improve the heart survival rates, heart failure survival. So goal therapy of the heart failure, we need to increase the survival and reduce mortality, reduce rehospitalizations, and make feel better, right? Like we need to improve the functional class, quality of life, and this should be the goal of heart failure treatment. So how was the journey of RCTs in heart failure? Drug and device trials, we know that ranging from 1986 to 2001, where we have trials on beta blockers, on like Merit and Cibis trial, spironolactone trial, and different Copernicus, ACE inhibitors, ivabradine, all these trials, what they lead to us that we need to have a big step forward for keeping our patients to improve morbidity and mortality. Paradigm heart failure trial, in which it is a landmark trial which shows that ARNI combination is quite helpful. So the clear, I'm not going into the details of eligibility criteria, but the largest mortality and morbidity trial in patients with reduced ejection fraction, most geographically diverse trial in patients, and more radically diverse heart failure. So the medical therapy for stage C with reduced ejection fraction, the mortality is reduced by 17% by ACE, 34% by beta blockers, spironolactone 30%, hydrogen nitrate 43%. So ARNI, which is the important drug which has come of late, which reduces mortality by 20%, NNT for mortality reduction 32, and relative reduction of heart failure hospitalization by 21%. So INYC classes after ARNI initiation is quite significant. After 30 days treatment with this combination, a significant improvement in INYC class was found in approximately 1/3 of the patients. And after the treatment, the percent of patient in class 1 was again 32.4%. So 1/3 of the patients, they come into class 1, which could be the target of our treatment whenever we are treating our patients of heart failure. ARNI is superior to ACE inhibitor across the subgroup of chronic heart failure, whether they are aged, whether they are having mild or moderate or reduced ejection fraction, whether they are renal failure patients, hypertensive, non-hypertensive, whether and pro-BNP is high or not.